It's 1 o'clock, so we will start the meeting. Who's doing the live stream? Is that?
That'll be, yeah.
Yeah, live stream. Welcome to the meeting of the Health and Wellbeing Overview and Scrutiny meeting of the 3rd of May 2022. The meeting is being live streamed, will be available online. And can I remind you to turn mobile phones off or onto silent. And I'll just carry on. We're just going to have a change to the agenda. CNCW are here. Their presentation was further down the agenda, but they are here, and the other two presentations are going to be done on screen. So we'll take that item at the beginning of the agenda. So apologies for absence. I have Councillor Ferguson's. I don't have anybody else's. What is that? Disclosure of members' interests. Do we have any disclosures from anybody? No? All right. Forward plan. Chris, do you want to take us through the forward plan? I can't see anything.
The forward plan is just to note on this version.
Okay. Health and Wellbeing Board. The minutes of the Health and Wellbeing Board held on the 10th of March and the 14th of April are attached for the scrutiny of any issues. Does anybody have any issues they'd like to raise from the Health and Wellbeing Board? No? Okay, thank you. Reports for consideration by scrutiny, right? We've got a big agenda today, so we're going to take the scrutiny, the reports, but can I ask when we come to questions that we make them fairly concise to get through? I will remind us all, and I know Councillor Dodd will anyway, that we have a planning meeting in here at 4 o'clock, and they will need, again, to set up their equipment and make sure that everything's working. And by the way, welcome to the Council Chamber. It is our first meeting in the Council Chamber. So we're on to the item number 5, the North East no. Whoops. The Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust Quality Accounts. We have Lisa Quinn and Paul Sands. Can I just pass over to you?
Thank you.
Yes.
Thank you, Chair. And thank you for inviting us to the committee. We've come to present our draft quality account. I've been here many times before, but thanks again for coming back, and it's lovely to be in person. We're just going to take you through a small presentation which brings together the highlights of the quality priorities themselves, and more than happy to take any questions at the end of the presentation, if that's all right. Next slide, please, Luke. So just looking at the last year, clearly we've gone through unprecedented times over the last 2 years, and when you look at the services within mental health, learning disability and autism services, we kept going throughout the pandemic, open to the population of Northumberland and other areas appropriate to the Trust as well. And in the last year, we've seen an increase of need in mental health across all ages, and we've seen a particular increase needed within the children's services as well. So this first slide, the donut sort of shows the breakdown of our weights and referrals to our services for community services. 25% of our weights at the moment are in the ADHD pathway, 13% in ASD, and then the vast majority of services is that 48%, and then 14% for children. But what you can see on the right-hand side of this presentation is we've managed to maintain access in a timely manner, particularly for children's services, and we've been able to maintain that throughout the pandemic, which we're really very proud of, and also it's an extreme effort for the community staff, and they've gone the extra mile to be able to maintain that level of access to our population. Next slide, please, Luke. In the neural services, so the ADHD adult ADHD services and ASD services, we have continued to struggle in those two areas. And you'll hopefully recall from previous years, we've had extended waits in these neuro pathways and really look to prioritise how we reduce those. And we're working with the commissioners, those in the Northumberland commissioning group, as well as other areas across our trust, to see what we can do around these pathways for the next year. And I'll say a little bit more about that later on in the slides. Within all other services, which you saw was the vast majority on the previous slide, again, we've been able to maintain access across all of our disciplines again during the pandemic. So again, great credit to the community services that have managed to do that. Next slide, please, Luke. So we had 4 quality priorities last year, and the pandemic did impact on our ability to progress at the pace that we wanted to. We were able to make small progression through them, but we are looking to continue those priorities in the main through next year as well. Next slide, please, Luke. Thanks. So in relation to that, we have declared in the quality account that 3 of those priorities are partially met. The one around inpatient experience, the one around access, as you've seen in the previous slides, we've maintained a level of access, but we haven't improved the way that we'd like to. So we're continuing on with that. And our equality and diversity quality priority, we're looking to continue on with that as well. But our priority, which is predominantly from feedback from service users and carers, we are looking to adapt that and reflect on the feedback we've heard from service users and carers and from and the public as well in relation to what matters to them over the last year. In the previous year, it was around activities in inpatient settings. That's no longer a theme coming through in the feedback. But what we have had is just short of 3,500 bits of feedback from our service users that have asked us to work on hearing them, listening to them, being heard within our services. And that's what we'd like to change the quality priority to over the next year. Next slide, please. Thanks, Lou. So that feedback was over the last 12 months. Paul went through every bit of that feedback and reviewed it all, and there was a common theme around being heard within our services as well. So we would like to adapt the quality priority we have around patient experience to reflect the feedback that we've heard in the quality account itself. Next slide, please. So next year, or certainly this year that we're in now, we'd like to focus on 4 main priorities. The 3 that we've carried forward from last year about improving our inpatient experience, improving our waiting times, recognising clinical services have done a fantastic job over the period, but we'd like to go further. Listening to our service users and supporting our service users and carers to be heard. And then the final one is around equality and diversity and inclusion, including human rights as well. So that's really the focus of our quality account over the next 12 months. You'll see within the quality account draft that you've had shared with you a lot of information about the organisation and a reflection of where we've been over the last 12 months. But presenting here today, the quality account and those priorities we'd like to focus on over the next year. Next slide, thank you. So just in a little bit more detail, improving the inpatient experience. We did get to a point where we didn't have the need to access beds outside of our organisation, but over the last year we have started to need, as a consequence of demand, to use services outside the trust, which is not where we want to be as an organisation. And we also want to improve the experience people have when in our services as well. So we want this quality priority to continue to look at the purposes of admission and actually having a purposeful admission and a good experience when admitted as well. So we'd like to continue that. Improving waiting times, we'd like to really focus on those areas where we've got long waits, and those are predominantly in 3 areas: the ADHD services, the ASD services and the gender services. So those are the three areas we'd like to really make some improvements on over the next year. Next slide, please. Thank you. In relation to point 3, we haven't done a great deal of work yet on defining this priority, because it's what we've heard from service users. We want to involve them in actually shaping this quality priority. So we want to co-produce and refresh what we do with our service users within this priority itself, and then monitor the impact of that over the next year. And in relation to the fourth one, we want to see this priority from a workforce and staff perspective, but also from a service users perspective as well. So working on improving the workforce race equality standards, but also reducing disciplinaries and grievances that we have across the organisation, particularly from minority groups of staff. We'd also like to reduce restrictive practices within our inpatient areas as well. So that's, in a nutshell, our quality priorities for the next year. Next slide, please, Luke. I hope that has explained where our focus would like to be, and I'm happy to take any questions. Thank you.
Councillor Hill.
Thank you. Just a quick one. On page 187, just what you just mentioned, reducing disciplinary and grievance cases relating to bullying and harassment. Is it unusually high, or is it just there are some which we'd expect in any organisation that size and you just want to reduce it to 0, or is it evidence that it's unusually high, which would indicate a wider problem?
Thank you for the question. So we've looked at our staff survey results, and we've looked at the feedback from our workforce, and we do have proportionately a higher number of cases in our black and ethnic minority workforce compared to our white workforce. Is it unusually high across the country? I would say probably not. But it's not where we want to be in our workforce. Irrespective of your background, we want you to have a good experience of working for CNTW. So this is why we focused on this particular area for our workforce, because we do see a difference in our workforce as a consequence of their race.
You said ethnic minorities, are they saying racist incidents, or is it just this, saying that there's been bullying, harassment, and that demographic is from complainants is from ethnic minorities?
So we do see different results for our black workforce. Now, our workforce is more representative of different backgrounds than our population in our organisation. So when you look at the population of Northumberland, I'm going to get the figures wrong, but it's roughly about 98% white. That's a different demographic when you look at our workforce itself. And we do see a difference that we'd like to address, particularly for our black workforce.
Councillor Hunter.
Thank you, Chair. Mine's more on page 186 about improving the waiting times. I'm just wondering, through COVID, where we've had the lockdowns, and has that maybe exacerbated the situation by maybe more people needing support, so therefore that's impacting on your waiting times? I'm just wondering if there's been more people coming into the service that way.
Thank you. Yes, we've definitely seen referrals increase as a consequence of COVID. We've seen referrals increase across all of our pathways, but as I said previously, particularly in children's services, we are seeing a steady increase in the need for our services as a consequence of the last 2 years in the pandemic.
Councillor Bowman.
Thank you, Chair. It's related to your quality priority 1, embedding new ways of working relating to admission and discharging processes. Can I ask about the discharging processes? Are you looking for exciting new ways, or are you just trying to tweak what you've already got? Can you elaborate on that, please?
Yes, again, thank you very much for your question. We are experiencing an increase in delays as a consequence of people's need to move on from our services at the moment. We want to work with partners on a greater, a better experience of when you've received the services needed and you need to move on to a different pathway, whether that's back to home or back to a different service. We want that experience to be more timely and more seamless. We're experiencing significant delays at the moment, and people are staying within our services much longer than they need to. So that description is shorthand for improving that for the person involved, which also will lead to greater access for others as well. But we're seeing the increases across all pathways, but particularly in older people and learning disabilities at the moment.
Yeah, thank you.
Any other questions? I've just got one, which is obviously one of your priorities is the waiting times for ADHD and ASD people. That is long, and I appreciate it has come down over the years I've been looking at it. How confident are you of getting that to a more reasonable waiting time?
So it has to be our ambition, Chair, to get that to a better waiting time. Due to the extent of the delays and the extent of need at the moment, I think I'd like to see progress made through this year. It would be wrong of me to say that we'll address it in this year. We need support and help from partners to do this, as people being referred and need for us, they haven't got an onward transition within these services either. So we have got extensive waits. So I'd like to see improvement, but it's going to take some years to come to be able to address the overall position. But we're seeking support from our partners to do that.
Thank you. Are there any other questions? Anything else you'd like to add to the committee?
Just really to say thanks very much for the opportunity to come, and we look forward to your letter, and any suggestions of improvements in the account would be greatly received. Thank you.
And thank you both very much for coming. We really appreciate it. Thank you. You're welcome to stay or you're welcome to leave. That's way out through there. Yes, thank you. Now, we're going to go now to the North East Ambulance Service Quality Accounts, the accounts for 22-23. As you can see, we've made already, these are going to be online. So I think we have Tracy Gilchrist, is it? Tracy? Can you hear me?
Mark's going to do the presentation, if that's okay. So if I could relinquish the screen to Mark, please.
Okay, thank you.
Good morning, Chair. Sorry, good afternoon. Apologies we couldn't be with you today. I tested positive on my lateral flow test for COVID, so I'm sure you wouldn't want me in your council chamber with a result like that. So I'm grateful that we're able to do this online. Are you happy that I share my screen with everybody?
Yes. Can I just say thank you for still doing this? We are glad that you're able to. Thank you. So yes, if you would do that, and cross your fingers that this works well. Thank you.
I'm hoping so, Chair, although I've just tried to do share screen and I'm not getting the desired result on my laptop, actually. Is there somebody, does Chris have a copy of the presentation that he's able to put up for members in the room? Oh, okay, wonderful. I appreciate that. Thank you, Chris. If I just go through the presentation, then there are a lot of slides, but we're going to be quite quick on this if we can. If we could just move on to the next slide. I'm just going to do a very brief presentation on performance across the service and in the Northumberland area, and then Tracy's going to move on to our quality priorities for the coming year. So, as the committee will be aware, we handle 111 calls as well as 999, And you can see there over the last year, we did see a spike in increase in 111 calls, which has died down over the course of the over the period of the year. But you can see our time to answer those calls has increased significantly because of the nature of the calls that we're receiving now as a result of the pandemic is very different to what we were expecting before the pandemic. We've taken action with this with both NHS England and our commissioners. We're now a third of the way into a recruitment programme to bring 152 new call handlers into our control rooms in order to manage the complexity and length of those calls, so that we're able to answer them more quickly. And we had 53 that just started with us last month. Next slide, please. Just very briefly, 111 calls have a number of different outcomes, as you can see there. Almost the majority, the biggest proportion of those are into primary care. You can see that there's a larger chunk there of ambulance dispositions for 111 calls at 17%. The actual number of those calls that actually get in ambulances much closer to the national average of about 7%. That other 10% are dealt with by clinicians in our control room who are able to take the triage of 111 calls a little bit further than our call handlers. Next slide, please. When 999 calls come into the control room, you see, unlike 111, we have seen a significant increase in 999 call volume, particularly over the last winter. And I think, like many other parts of the NHS, we found that very challenging for us. And you can see there that the number of those calls that are dealt with over the phone in the Northumberland, in that green line, is a little bit below the average of the rest of the North East Ambulance Service area. Next slide, please. In terms of where we do send an ambulance, responses are broken down into 4 different categories. And the first category is for life-threatening calls, and we have 2 responses that we measure here. One is an average response time, and you can see there that the target for an average response time is 7 minutes. And in Northumberland, we have averaged that response time across the last year at about 8 minutes, and that's reflective partly of the rurality of the area that we are dealing with in Northumberland, and some of the issues there just in terms of travelling to patients. If I could have the next slide, please. But to give you the committee some assurances, we are the best performing ambulance service in the country for the average response time to category 1 calls, as you can see there. Next slide, please. The other element of category 1 that is measured is that 90% of all incidents must have an ambulance response within 15 minutes. And you can see that that has been achieved in Northumberland by a couple of months, once in December and once last July, where we were just over that particular target. But other than that, well within the standard there for getting an ambulance within 15 minutes to 90% of all of those incidents across the whole of the county. Next slide, please. And you can see that other than the London Ambulance Service, we are, again, one of the best performing ambulance trusts in the country for performing against that standard. If I could have the next slide, please. The next category of call is for is category 2. So these are emergency calls, but they are not necessarily immediately life-threatening. And you can see there that the average for responding to all of these calls is 18 minutes. And you can see that both within Northumberland and also across the whole of the North East Ambulance Service area, we haven't achieved that particular standard. Although I will say that Northumberland CCG area has the fastest response time for the average response in category 2. And you can see there that Northumberland is well below the blue line for the rest of the North East Ambulance Service. Next slide, please. And while no ambulance service in the country achieved this standard for the whole of the last year, the North East Ambulance Service was still by far the quickest in that particular response. Next slide, please. And you won't be surprised then, so the other standard here is that 90% of these calls must have a response within 40 minutes. And you can see there that that wasn't achieved either in Northumberland, although the Northumberland responses for these types of calls were a lot quicker than they were for the average of the whole of the North East Ambulance Service. Again, next slide, please. And that we were the best performing ambulance service in the country for this particular measurement, even though no ambulance service in the country was able to achieve that standard for the last 12 months. Next slide, please. The third category of call, so these are no longer emergency or urgent calls, emergency or life-threatening calls. There is only one measurement against this particular standard, and that's that we must achieve a response within 2 hours to these calls in 90% of all incidents. And you can see there with the red dotted line marking the 2 hour mark that the North East Ambulance Service area didn't achieve that standard for the year. And while we didn't achieve it in Northumberland for most of the year, we did in January and February of this year. We were a lot quicker in Northumberland to this response standard than we were across the whole of the North East Ambulance Service taken as a whole. Next slide, please. And other than the Isle of Wight, we are again the best performing ambulance service in the country for this particular standard, even though no ambulance service managed to achieve this standard at all for the whole of the last year. Next slide, please. And then finally, the fourth category is for non-urgent calls, and the standard there is that we must achieve a response within 90% of occasions in 3 hours. And you can see there that that was achieved on most months over the last year within Northumberland, although we missed that particular standard in September and October of last year and of June of last year. But again, Northumberland showing a lot faster response to this type of category than the rest of the North East Ambulance Service taken as a whole. Next slide, please. And familiar story here, again, North East Ambulance Service, the best performing ambulance service in the country against this particular standard, even though no ambulance service managed to achieve that standard over the course of the last year. Next slide, please. When an ambulance crew arrives, there's one of three particular outcomes, what we call see and treat, where the ambulance service will treat the patient on scene and leave them there, or perhaps refer them on to an alternative service without conveyance. And you can see our see and treat rates were a little bit below that of the regional average, although over the winter we are on a par there. We can convey to a non-emergency department, so this is something other than an A&E unit, and you can see there that our conveyance to non-emergency departments in Northumberland, green line, is slightly higher than it was for the rest of the North East Ambulance Service. Or we can convey to an emergency department, which in this case will either be the Northumbria Hospital at Cramlington or the RVI Hospital in Newcastle. And again, quite a big variation there, just reflective of some of the numbers in that. Next slide, please. When we get to hospital, it's been well recorded in the past on ambulance handover times. This is measured in two particular ways. One is the first 15 minutes upon arrival for the handing over of a patient into the hospital, and then the second 15 minutes after the handover for the ambulance to clear before it's on scene again. Sorry, these two graphs are the wrong way around if you were to look at it in that logical sequence. You can see handover time across the whole of the region have increased, particularly as we moved into autumn and winter last year, and that's symptomatic of the pressures that were being felt in hospitals right across the region. Not surprisingly, our time to clear after handing over the patient has similarly decreased. Our expectation is that as we begin to improve handover time, that handover to clear time will start to go up a little bit, and it evens itself out. But crews obviously have more time to prepare for clearing when they're still waiting for the patient to hand over to the hospital. Next slide, please. Of course, you'd be interested in the handover to patient at hospital at the Northumbria. And you can see there the chart for the pressures that have clearly been felt at that particular hospital when we've been waiting to take patients in there and have them handed over. And you can see there that that's measured by the 1 to 2 hour clock, and also anything over 2 hours, and the number of hours lost in each month as a result of those delays. Next slide, please. Just moving on very quickly, just to come to the end of this part of the presentation, we also do scheduled care journey. So this is for patients who have a clinical need for transport and for appointments or elective surgery. And you can see here that that dropped off dramatically at the beginning of the pandemic a couple of years ago. And we are slowly beginning to bring that back up to where we were pre-pandemic. We're not quite there yet because we still have some restrictions that we put into place with patients. So you can, for those that are familiar with the service, you'll know that before the pandemic, we used to carry multiple patients on board one vehicle. Obviously, these patients, because they have a clinical need for transport, are by that very nature also vulnerable. So we're protecting them from the virus by just carrying single patients or no more than 2 patients on the vehicle. And of course, that is restricting us with the model that we had previously, where we're carrying multiple patients in. So it's taken us a while to get back up there. But this is an important part of the work to support hospitals and the rest of the NHS to clear the backlog of elective cases that they are quickly working on. So that's an important element for us to get right as well. Next slide, please. And just like the rest of society, including myself today, we're not immune to the virus, and you can see there that sickness absence levels have increased over time. And this has been a challenge for us. While it's easy for me to be here today virtually, clearly you can't have a virtual ambulance responding to a patient. So that does put pressure on our service when we don't have the staff able to respond appropriately to those patients. Next slide, please. And you can see there some of the issues impacting on our performance. We've seen an increase in the acuity of patients that we've been dealing with, but should put a pressure on some of our response times. Demand has been very difficult to forecast because we've not experienced a global pandemic like this before. And clearly the impact of that is on sickness, on staff shielding, and also the cleaning routines of our crew, who will clean and wipe down the vehicle after every patient. They'll do a deep chlorine clean of the ambulance in every shift, in addition to the normal cleaning regimes that we have in place prior to the pandemic, which have clearly put pressure on our service. There you can see that the cleaning vehicle hours has significantly increased over the last 2 years. Next slide, please. And I'm going to pause question for a moment and hand over to Tracy to talk about our quality priority for the coming year.
Thanks, Mark. Just in view of the time, if it's okay with the chair, I'd like to propose we skip forward to slide 28, which is the update on 21-22 quality priorities, and I'll cover everything at once that we did in the last year. So if we could go next slide, please. And again, and again. and again. Lovely. So I'll cover all the quality priorities for 21-22 in one part of the talk. So we had good progress despite the challenges that Mark's actually discussed in his part of the presentation. Obviously, we had a huge increase on demand in services, which obviously caused us some concerns about patient safety, and we were very proactive and used the clinical safety plan to allow us to allocate resources in times of demand and reducing the risks to our patients in the EOC. What we did with that was we actually allocated more clinical staff into the EOC, and they reviewed the patients in the queue, and we looked at dispatching ambulances for clinical priority rather than the length of time for patients in the queue. And that is something that we will be looking to take forward, because that was extremely successful throughout 21 and 22 in those high periods of demand. From a cardiac output point of view, the clinical effectiveness, we've increased the amount of defibrillators in the region and increased public awareness of where those defibrillators are via working with various organisations to get an interactive map that also links into our EOC as well, so we're able to safely direct people to those defibrillators to reduce the amount of time to get to them. We do recognise we've got more work to do. We need to look at, in the EOC itself, upgrading of peri-arrest situations, and we actually need to understand why in our region we are less likely to perform bystander CPR compared to other areas in the country. So we are actually engaging in some research in the background to try and help us and inform us for that. From an end-of-life point of view, from patient experience, we've had a very successful year, despite the fact that for half of the year we didn't have our end-of-life lead in place. She's now come in to her role, and she works for us and Newcastle hospitals. She's very enthusiastic and absolutely revamped our training for our staff, which has been absolutely fantastic. We've really increased awareness amongst our newly qualified paramedics, helping them to understand that we need to recognise patients' wishes and try and keep them at home as much as possible. We've increased the amount of DNA CPR documentation within our system, which helps us understand our patients' wishes better. But we do recognise we need to take that priority forward into 22-23. One of the things we weren't able to actually achieve was the 7-day end-of-life transport service, but we are hoping to introduce that soon. And then if we can have next slide, please. And next. And next. And next. So I'll then go on to our 22-23 quality priorities. So these priorities have been informed by what's going on in the background for the wider NHS. So from a patient safety point of view, we felt as an organisation that working with our acute trusts would be essential to reduce handover delays. We realise it's a system-wide problem. It's not just the acute trust problem. And one of the things that we'll be doing as an organisation in the background is trying to improve on our see and treat rates to reduce the demand on emergency departments, and actually providing information to each acute trust as a handover pack, as it were, so that they understand where the pressure points are from our perspective, and working with them to see what we can do more in the community to reduce the pressure on our local EDs and reduce the harm, the potential for harm for our patients waiting for long times. With PISA, which is the new Patient Safety Incident Response Framework, this is a national change on how we look at patient safety incidents. It's moving away from looking at individual incidents to looking at themes and how to improve your services by negating or minimising those risks within your system as much as possible. We will be working very closely again with the Acute Trust, sharing information between NIAS and the Acute Trust to try and improve care throughout the system. And then clinical effectiveness, that works hand in hand with the handover delays. We'll be looking to ensure that our patients have the best care, the right staff with the right skills at the right time. So we're looking to increase our amount of prescribers within the organisation to really ramp up that ability to provide care in the community rather than conveying our patients to emergency departments, working with the Falls team and looking to pilot our mental health car again to try and get as much help and assistance out for patients in the community as possible. And then finally, like our colleagues said earlier of our CMTW, as the COVID restrictions are becoming less restrictive in the backgrounds, we will be going out more to our communities to listen to their ideas on how we can improve our services, look to what they feel safer care looks like, and get them to be more partners in the care. We'd really like to take forward as the PHSO standards come in for patient complaints and the PSERV work, get more patient representation within our organisation so that we can listen to their views and that they can become partners in the healthcare and contribute to patient safety. Thank you very much for allowing us to talk today, and any questions?
Thank you, Tracy. And Mark, questions? Councillor Hill and then Councillor Dodd.
Yeah, I think when we've had this presentation before, we've asked if the data could be localised, because it would be interesting. I know people think in their own areas. I'd be interested in what the data is, response times for Berwick-on-Tweed. I mean, I know the cycle I've been involved in since I've been a councillor. And I imagine Isabel will agree with me, obviously she can say, but I know that in the next few weeks or month or so, somebody's going to say to me, there was an incident on Saturday and somebody had to wait an hour for an ambulance. It was serious, they had a heart attack, or they had a very nasty accident and they were in absolute agony. And this happens not infrequently. And also, more pertinently, you know, from an evidence point of view of wider problem, whistleblowers or people I know who work within the ambulance service, who serve Berwick, have actually said to me, obviously on the QT, I'm not going to give names, but have said that they're really concerned that areas which are more remote, more sparsely populated are not served as well because the ambulances want closer to the higher population areas. So my guess why I'd be keen to get localised data is that our stats would be lower than elsewhere.
Could I respond to that, Chair, if I can? I'm afraid we're not able to produce localised data below that of the CCG level. And that is already more localised than the funding which flows through for ambulance performance and the measurements that are set for by NHS England. I appreciate the point being made by Councillor Hill. You know, she's absolutely right that isolated or rural areas will, on the whole, have a slower response time to those in urban areas. But as I pointed out in the response category 2 calls, on the average, that's the fastest in we have the fastest response times in Northumberland than any other CCG area. And that's typically because while the distance to travel may be further, particularly to isolated locations, there is less likelihood of that ambulance being diverted to a more urgent call, which is something that more frequently happens in urban areas, which is why we are so quick at our category response times, but at the expense sometimes of our category 2. So the standards which were set by NHS England were set it would be a few years ago now, about 7 or 8 years ago, partly with a purpose in mind that there will be challenges in meeting those response times. Not every area can achieve a response time standard because there will always be challenges, which is why we moved away from the original 8-minute response in 75% of cases, because that did not measure the 25% of cases that didn't achieve that 8-minute response. So while we have a 90-minute response standard within a particular time, the other standard that I mentioned, the average response standard, does also include all of those cases that didn't achieve that 90% response time. So the longer we take to get to a particular individual case, the longer our average response time becomes. And you can see that the average response time in Northumberland is 8 minutes, compared with the standard there that should be 7. Sorry, I think I hope I've answered the question there, but I am sorry we're not able to provide data at a more localised level.
I mean,
than the CCG.
If I could just come back, I mean, from the point of view of Berwick-upon-Tweed, it is a population of 13,000 people, and we are the furthest away from a major hospital anywhere in Northumberland. I know sometimes they talk about ambulances being mini hospitals and can do that, so you'd think we would be more served because we're further away from a major hospital. I mean, the point about this data, whose decision is it? Because surely, I mean, I don't know what your database is, Luke, but surely there is some spreadsheet that says, 3 minutes past 5, ambulance called out, ANIC, postcode, heart attack. Well, there'd be something. So it really wouldn't look like a data problem to separate it by postcodes to be able to get localised data. A cynic would say, you don't want to have that localised data. I'm not blaming you, but whose decision is it to not extract I'm no data expert, but it would seem to me quite a simple, wouldn't be a complicated thing to break down by postcode area.
Right. You're quite right, Councillor Hill, that the data is already there, except for the rules, which would be which postcodes sit within which boundaries and at what data level would we go down to, because there's nothing set for that. The other issue for us would be simply that of capacity. And that's something that we have experienced quite a lack of over the last 2 years. We've focused our attention on dealing with the pandemic, is actually how much spare capacity we had is now taken up in that particular response. So if we were to look at this data issue, the data is there. It's taking the capacity of taking the resource of someone who's looking at that particular data away from something that is being currently measured in order to look at this. If there's a particular request for response times in the Berwick area, I'm happy to take that away as a one-off, but I think being asked to produce this on a regular basis, particularly over a larger area than that, will cause us capacity issues. But by way of assurance, Councillor Hill may be aware of this, but we received funding from the Northumberland CCG earlier in the year to make our community paramedic scheme up in Northumberland, which we've been running as a pilot into a permanent scheme. And that not only helps us to achieve fast response times to those patients, but where those patients aren't then necessarily needed to travel to a hospital, there's a resource there to then respond to the next patient while an ambulance may also be travelling. And the final thing I would mention is that because She's quite right to say that Berwick is a long way from the nearest hospital. When an ambulance does travel to hospital with a patient, we do have protocols in place in our control room to ensure that we move other ambulance resources, move them around and closer to the town, so that North Northumberland area isn't left exposed without an ambulance when a patient is travelling.
Thank you. Councillor Dodd, and then it's Councillor Bowman and Councillor Hunt.
Thank you. Hi Mark, I was on the Ambulance Trust for 9 years, I think. So I've got a fair bit of information about it in my head. And way back, because some of these targets, I think, may be out of date. I mean, if you live in a remote area of Northumberland, it's not going to be the same as living in the middle of Newcastle. So I think you have to accept that there will be some changes. But I think the targets, and I go back a while, and there was an obsession with targets. And they employed people called clock stoppers or watch stoppers to try and get these targets hit. And, you know, let's face it, according to those figures, the best place to be if you need an ambulance is in Northumberland or, you know, in the northeast. So it's not all bad news, but I do think that the criteria that these things are measured at, or the targets that are set, might be a little bit unrealistic in this new COVID world, higher population, and there's a lot more vehicles on the road. I mean, roll on the dueling of the A1, you'll get looked at quicker, Councillor Hill. But it's one of those. Well, yes, we hear this all the time. We hear it from Hull, so all the remote areas always have a problem. But that's why the remote areas, and I just wonder if the targets fit the bill anymore. I would welcome your thoughts on that. And my second question is, we suffered Storm Arwen, and I saw something on the slides about defibrillators, which is wonderful stuff. But do they work if there's no electric? And I think that's something that we might need to address at some point in more of these remote areas who will not guarantee electric. Thank you. Cheers, Mark.
Thank you very much. I think that first question would possibly be more of a comment than a question. I would say that the targets aren't within our gift to change. We're not marking our own homework in that respect. They are set by NHS England, and they apply across the whole of the country. But I do think Councillor Dodd makes a good point in making sure that these are regularly reviewed and are still relevant to patient needs today, as they were perhaps 8 years ago when they were set. But that will be a matter for NHS England to pick up rather than an individual ambulance service. With regards to the defibrillators that he mentioned, if there is a power cut, the defibrillators are powered by a battery pack rather than which will be on a charge. If they're not being used, that battery pack will last a while. I couldn't tell you for how long, so they should still be good to work. More crucially, we have now seen all of the public defibrillators that are on our system moved across to a centrally controlled database, which is managed by the British Heart Foundation, so that whenever a defibrillator is used, that's recorded centrally, and someone from the British Heart Foundation ensures that the owner or keeper for that particular defibrillator make sure that any replacement parts that were used are replaced, and any batteries that need powering up or changing or replacing are also occur again before that defibrillator is shown back on our system and ready to use again. It's hopefully going to be a much more effective system than what we had before, when ourselves with an ambulance service were having to manage each defibrillator with each individual keeper for that defibrillator. Now that's been taken out of our hands and is managed essentially by the British Heart Foundation, who got resources to do that in the way that we didn't before.
Thank you. Councillor Bowman.
Thank you. Thank you very much for looking into the improvement of end-of-life care. It is a very important facet, and it is often missed, as it were. I'm sure that many residents in our communities would appreciate everything that you do in that area. So thank you for that. There is an issue regarding the time of ambulances coming to a scene of an incident. You've got various categories. I understand that. I understand the reasons for doing so. But we've got a problem where I live in Seaton Delaval and Holywell, because the emergency care hospital is literally less than 5 minutes by car, and yet you can wait 2 hours for an ambulance if you're lying on the ground bleeding. And the residents are saying to me, this is a nonsense. The hospital is just round the corner. Why does it take 2 hours for an ambulance to turn up? And I try to explain to them about the various categories. But you can see their frustration, can't you? That there's the hospital. We can see it across the fields. And yet it takes 2 hours for an ambulance to turn up. Can you explain to me why that is? Why it is that we can't divert an ambulance that's returning back to a base or whatever it may be, to reroute and go to a scene that maybe you categorise it as 2 hours, 3 hours, 4 hours for collection time. Why is it that we can't use ambulances going back to base? Thank you.
Thank you, and that's a good question. We can and we do. Ambulances will often respond. They're very mobile units, and will rarely spend time on station, but will move from job to job. I think the presentation perhaps showed, but I went through it a little bit too quickly, as to why there is a challenge there. We've seen an increase in 999 calls, so we're now responding to more emergency patients now than we have ever done before, but with the same amount of resources to try and do that. Coupled with what I said earlier as well, that living with COVID now, we do have staff sicknesses. We're currently somewhere around about 12% of our workforce is off at any one point with staff sicknesses, including COVID. And while we do use third-party resources like St John Ambulance or British Red Cross to fill some of those gaps, at the moment, sometimes we just don't have enough people in a particular day to push out an ambulance in order to respond. Where we are pushing out those ambulances, we have to be very conscious that each patient is treated in a sterile and a clean environment as possible. We wouldn't want a patient who we conveyed into hospital who was COVID positive to leave any kind of that virus behind for the next patient who may not have COVID to pick up. So you would have seen in the chart that I was showing you earlier that the time taken for the cleaning regime on board the ambulances by crews has significantly increased, and that remains the case now. And then I think the final point is just around that hospitals. Hospitals have experienced their own pressures as well, and will sometimes find it challenging to take a patient from one of our ambulances when we arrive at the hospital. And you would have seen in one of my other charts there that there have been hours lost and delays for patients for us to hand over a patient to hospital of between 1 to 2 hours. sometimes, and while an ambulance is waiting to hand over a patient to hospital, it's not available to respond in the community to the next emergency call, even if that community is only 5 minutes away from the hospital. Until that patient is clear off the ambulance and handed over to the hospital care, the paramedic crew that are looking after that patient and unable to respond to the next incident that may be waiting. And that is a risk for the patient. It is something that, thankfully, here in the Northeast, we don't experience the high levels of handover delays that we see in other parts of the country. And it is something that has become quite a high priority for NHS England and the NHS right across England to ensure that this is addressed, so that people waiting for an ambulance in the community aren't at risk from a delayed response due to an ambulance waiting at hospital.
Thank you, Mark. Councillor Hunter.
Yes, thank you, Chair. Thank you, Mark. I've been a campaigner for many years on this committee for the ambulance service in the rural areas. When we get the times of arriving on scene, if the first responder arrives first, are they the one that stops the clock ticking, or is it the clock only stops that you've arrived on scene when an ambulance actually arrives? And another question is, the coastal area in North Northumberland, like a lot of areas, is very much a holiday season tourists. We've got 2 large holiday camps which are expanding in our area, as well as bed and breakfast and other holiday lets. Can you use this, because of the more people coming in the summer, as a way to try and get additional resources and funding through the CCG, because it's putting an impact on your service? As well as we support the Great North Air Ambulance, which yourselves do, because it's a great support to you in the rural areas.
Thank you, Chair. 2 very good questions there. In answer to the first one, and I think Councillor Dodd raised this earlier, so apologies I didn't cover it off at that particular time. The clock only stops on the response time target when the most appropriate vehicle or the most appropriate person for the patient's need arrives on scene. So if you're a category 1 patient and a community first responder is the first on scene, they may be able to start that initial care and treatment and begin to support and stabilise the patient. But that's not what the patient needs, so the clock does not stop. If the patient requires transport into hospital, then sending a rapid response paramedic, again, with all of the drugs and equipment and skills that they have, will help to support that particular patient. But if ultimately they need transport to hospital, let's say they're having a stroke, then a rapid response paramedic will not stop that clock. It has to be the most appropriate response to the patient's need that stops the clock, rather than necessarily the first response that arrives on scene if that doesn't meet the patient's need. That wasn't always the case. That used to they used to be the first recourse would stop the clock, regardless under the old standards. But under these standards, which as I said have been around for about 8 years now, that's been the particular case. With regards to the second question around seasonal demand and increase, we have a lot of historical data around all of this, which we do use to plan and forecast. And we have identified that there is a requirement for additional resources into the ambulance service. And we are in quite, we've been in conversations, positive conversations with our commissioners now for quite a while around what that additional, what funding may be available for that additional resource. So I'm not quite sure we're there yet to make any sort of announcement, but I'm not sure that we're far off it. But clearly there's been a recognised need for the fact that you've seen the standards that I've marked there. While we're the best performing ambulance service in the country, we're still not achieving those targets. And that is why we are still the best performing ambulance service in the country. There is a need for us to ensure that we are able to meet those targets, because that's the only way that we can ensure the reduced risk to patients and the best chance for patient safety in our responses.
Thank you very much. And there's no further questions. So Mark and Tracy, thank you very much indeed for coming today, or for rather being online. And we will submit the formal response to the Trust following today's meeting. Thank you very much indeed for coming. Thank you.
Thank you, Chair.
Thank you, Tracy. So, Newcastle? Yeah. So we're going to go on to the next item, which is the Newcastle upon Tyne Hospitals NHS Foundation Trust Quality Accounts for 2022 to 23. We'll just see, this one will be online as well.
Okay, good afternoon, everybody. I'm Angela O'Brien. I'm the Director of Quality representing Newcastle Hospitals. I'm joined by colleagues Helga Charters, who is an Associate Director of Nursing with a remit for children across the organisation, Cheryl Teasdale, who's an Associate Director of Nursing with a responsibility for clinical standards and practice, and Sam Rutherford, who is the Head of clinical effectiveness and quality assurance working in the clinical governance department. Anne-Marie Troy-Smith also joins us, and Jack Bell, both from the clinical governance team. So we're going to do a shared presentation. So can you see our slides?
Not yet, we can't, no.
Okay, I think they should be coming.
Yes,
Can you see them
yes.
now? Yeah, okay,
Thank you.
thanks. Could we advance to slide 2? Jack, are you controlling the slides? Thank you. So I was just going to give a brief reflection over the past 12 months to council members and update you on our position with regards to the pandemic, and then we'll in turn update you on progress against our quality account priorities that we set last year. So I think it's fair to say that we didn't have a looking glass at this time last year, and when we met with you, we had hoped that the pandemic was largely behind us. Maybe just as well we didn't have a looking glass at that time, because actually what was to come was possibly more challenging than what we had already been through. So you'll notice those have had an opportunity to look at the quality account document in full, that on page 6 there's a chart that is the 2020 to 2022 timeline, which I think beautifully illustrates all of the various peaks of COVID and the subsequent peaks in staff absence. So where we had thought that the January peak, the January 21 peak, was the worst that we could have encountered, because at one time we had 160 inpatients with COVID, and 100 of those were requiring high level care. So many that were imported from Birmingham and London and outlying hospitals within the region. We weren't expecting that the next January we would see a similar number of inpatients that we then received in January 22 with the onset of the Omicron variant. And why I say that this last year has probably been the most challenging was because of the staff absences that compounded the challenges of having 160 COVID patients in the hospital. So whereas during the first January peak, we had at the worst stage about 500 staff members off sick with COVID, whereas in the peak in January 22, we had 1,200 staff absent at one time with COVID, plus another 800 that were off with the usual seasonal illnesses. So there was a point where 2,000 staff out of our 18,000 complement were on sickness absence. So that placed a huge amount of pressure on staff and on continuing to deliver our services. We have seen an increase in the acuity of patients that occupy our beds, and this is shared across the country. So obviously we network with colleagues in other big teaching tertiary centres across the country, and the Shelford Group have seen a similar increase in the average number of comorbidities that a patient is suffering from when they're admitted to hospital. So that has gone from an average of 4 comorbidities to an average of just less than 6. So what we're seeing are patients that are a lot sicker. They have deteriorated considerably during the pandemic, maybe due to fear of attending hospital, maybe due to not wanting to place additional demand on an already overstretched service, so have sat on symptoms for a long period of time. So when they actually do come to hospital, they really are very, very poorly. And that has had an impact on our quality goals and targets that we set last year, which I'm sure Cheryl will go into in a little bit more detail. So like others, we're massively challenged now with our recovery programme. So we have more 104-week waiters than we've ever had in the past. It was a rare occurrence that we had a patient that was waiting 2 years for surgery. 1 year is unacceptable. 2 years is really extraordinary, but sadly in some of our more complex surgical specialties like neurological spinal surgery, we have patients that have been waiting for 104 weeks, which is challenging us, as well as 52 weeks and 78 weeks. We have managed to continue with cancer surgery without any delays to cancer surgery during the pandemic. But some of our diagnostic procedures and weights have increased, which is contrary to where we would like to be performing, because of the demand and the requirement for distancing. It has been a period that has expedited many, creative ways of virtually engaging with patients, and virtual appointments, telephone consultations, did the use of digital technology to assess patients using photographs rather than seeing them face to face. And we have cut down on a lot of journeys to hospital, associated carbon emissions, and taken out a lot of the stress and anxiety and hassle for patients making their way into the city if they don't live close to the city, and many of whom have expressed a preference to continue with their engagement with the hospitals on a virtual using a virtual platform. So whilst it has expedited many of the use of technology that we hadn't seen pre-pandemic, it has also created for us this enormous backlog of patients awaiting elective surgery. So there is a section in the report where we've put in some highlights of where we've made those rapid changes to providing advice and guidance to GPs, patient-initiated follow-up, which gives patients the option of whether they would like to come to outpatient clinic routinely after surgery, for example, or whether they would prefer to make that choice. In areas like cataracts, we've built 3 cataract theatres on the CAV site that has really transformed our cataract surgery provision. And if any of you live close by or have visited Freeman or drive past it, you'll see our day treatment centre that is currently being erected on the Freeman Hospital site to help us address some of these long delays and backlogs that we've generated through the pandemic. So I won't dwell on how we identify quality priorities. You've heard from the other trusts today, very similar processes. So if we just flick forward to slide 4, I think it is, Jack, that patient safety priority 1, and I'll hand over to Cheryl. Thank you.
Thank you, Angela. Hello, everyone. So from a priority 1 point of view, we wanted to reduce hospital-acquired infections, which was always a priority for us as a trust. However, it's been quite challenging in the last year, as Angela's just outlined there. From a COVID perspective, we've had a great deal of patients through, and that has taken our infection control team. A lot of their priority work has been with that patient placement and ensuring that we have that safe care, and that's really sort of demonstrated in our rates of hospital acquired COVID infections is the lowest in the region and indeed nationally. So we've done very well from that point of view. However, from other infections, we can see that we see diff rates. We're 157 at the end of last year, which was a national trajectory of 98. So we're quite significantly over that sort of national need. However, what we do know is that our microbiologists and our infection control teams, and indeed our clinical teams, have been really challenged in terms of antibiotic use. We're seeing a lot more patients admitted through the trust. That acuity is going up, as Angela's described, and we know that antibiotics have been used more, sometimes with lack of face-to-face appointments with GPs, and we know that C. difficile is often caused by that overuse of antibiotics. So that examination of the cases that would ordinarily happen has been difficult over the last year. That said, we know we've got work to do. In terms of MSSAs, again, what we had from an internal point of view, we had a 10% reduction requirement overall. However, what we found was that we haven't met that trajectory. We had 97 cases. However, what we have seen is we are lower than what our national trajectory is. So we have actually achieved that sort of reduction from a point of view of in trust, but we know that we've had more lines, drains, tubes, them things that increase a patient's susceptibility to such infections. And again, we know we've got work to do with that. From a gram-negative point of view, for E. coli infections, again, we had an internal priority of a 10% reduction, and we had 187. Our national trajectory was 228. So again, we're under that, but we're not under where we wanted to be as a trust. And we know that some of them infections it's use of antibiotics, catheters, for instance, and lines and drains, like I say, we have had a lot more of in the last year. Klebsiella, we had 138 cases. Again, nationally, it was 167 was our trajectory. However, we did have that internal, again, it's a similar theme. We're not hitting our 10% target of a reduction from an internal perspective. And similarly, Pseudomonas, we had 39. Our national was 54, but we didn't achieve that internal reduction of 10%. And we know we've got work to do, and I think we did think this time last year we'd be able to concentrate more on them other infections and perform reductions and achieve reductions in them things, but we haven't been able to achieve that. But we know that this year, we really need to concentrate on that, and hopefully we're hoping that, like we did last year, to be fair, but hopefully this year we will see that reduction in COVID-19 cases, and our infection control teams will be released to concentrate on that and work with the ward teams. That said, we have still seen some reductions in areas where we've had previous high incidents, for instance, in older people's medicine, in E. coli, the use of urinary catheters. We've worked with them teams, and they have achieved reductions in areas, but again, it's across the trust we've seen an increase overall. But the areas that we had problems with, we have achieved reductions. Could we go on to the next slide, please? Jack. Our second priority was that of pressure ulcer reduction within our Newcastle community patients. And what we wanted was the way in which these are categorised is that if a patient hasn't got the correct equipment in place, they haven't had the correct assessments to identify that they're at risk of pressure damage, then they would be a community acquired pressure ulcer. And so what we've done is we've looked at, there were quite small numbers anyway. If you think from 1920, it was 41 cases. However, we did have an increase last year, and we've seen, similarly to what we've seen in patients, our community patients were also, their acuity was going up. We've seen that reduction in mobility in our community patients. You know, I think the lockdowns had a significant effect on, you know, we've seen increases in patients coming through our services because of that. You know, ordinarily they'd be pottering around going to Newcastle city centre, and that they weren't able to do that. So we have seen that deterioration and conditioning overall. So what we did was we've increased education support within the community, updates on pressure ulcer reduction, and the leads in the community have also taken on ensuring that assessments, equipment, etc. is in place, and we have achieved quite a significant reduction of 42%, which is a great achievement for the community teams, despite all the challenges they've had also over the last year. Thank you. I'll hand over to Sam.
Hello, thank you. So priority 3, management of abnormal results. The management of clinical tests from their request through booking, performance, reporting and reviewing and acting on the result is a major patient safety issue in all healthcare systems. We see evidence of patient harm caused by delays in tests, resulting in delays in treatment, and aim to minimise those risks. This is a highly complex problem, and nowhere in the world has an infallible system that can guarantee an important result cannot be missed with an electronic patient record, paper or a combination of both. We aim to ensure that all clinical investigation results are reviewed by the appropriate clinicians so that they can make a timely clinical care decision and reduce the risk that significant information is overlooked, resulting in delays to treatment. To achieve this, significant clinical input is required from the digital health teams, clinicians requesting investigations, staff performing the investigations, and our technical teams to make changes in the digital patient record. We have appointed a clinical lead for the management of abnormal results and reviewed our trust investigation processes, starting with test ordering. We have agreed this work is a top priority for the digital leadership group and met with the Director of Radiology to agree axial radiology as a pilot for the inclusion of a mandatory field for the lead consultant on their order entry forms. We have entered into a development partnership with 3M to use their follow-up finder, artificial intelligence technology, to highlight the need for follow-up investigations indicated in free text reports, and develop this functionality to identify gaps in the closed loop from requesting a test to taking appropriate actions for patient care using the Trust's clinical data warehouse and document store. Progress to date has included the mapping of current processes, agreement of a programme of design and development, and the identification of the resources required to complete the work. However, the success of this change must be measured by a reduction in the incidence of patient harm arising from delayed action on test results, which will require long-term data collection. In the shorter term, other metrics will include the proportion of digitally endorsed results and the time taken between a report becoming available and action being taken on its result. Next slide, please, Jack. Thank you. So priority 4, the modified early obstetrics warning score, commonly known as MEOWS. In recent years, there have been a number of maternal deaths in England where the lack of a MEOWS system for pregnant women in hospital but outside the maternity setting played a significant part. At present, pregnant or recently pregnant women outside the maternity unit are not monitored using a MEOWS system, and observations taken follow the traditional model of NEWS, the National Early Warning Score, monitoring for non-pregnant patients. The need for early recognition and management of deterioration of pregnant women has been highlighted by the Mothers and Babies Reducing Risk by Audit and Confidential Inquiry, the Ockenden Report, the Maternal and Neonatal Safety Improvement Programme, and the Royal College of Physicians Guidance, which states all pregnant or recently pregnant women should be monitored using a MEAL system. The implementation of an electronic MEAL system outside the Women's Services Directorate would improve the quality and safety of patient care for those women and provide obstetric services with a daily list of pregnant or recently pregnant women, regardless of their location within the Trust, and therefore improve collaborative care. Our aim is therefore to create an IT solution to identify pregnant or recently pregnant women outside of women's services and develop an electronic MEAL system to replace the National Early Warning Score for this group of women. Currently, the IT solution is ready to go live once tested. There is a newly appointed clinical director for patient safety to lead on this project. A request has been raised within IT for the question to be added in relation to pregnancy status to assist the automation of the maternity chart. Success will be measured by the introduction of the identification of pregnant or recently pregnant women outside of women's services and that they are on the appropriate news chart. Thank you, Jack. Next slide, please.
Hello, I'm just going to present priority 5, which is enhancing the capability in quality improvement. So creating a culture of continuous improvement and learning across the Trust is important to deliver sustained improvement in the quality and experience of care for all of our patients. Our 2-year partnership with the Institute for Healthcare Improvement has really looked to accelerate this work we've been doing. And we've invested a significant amount of time for training in the scientific approach of quality improvement to really increase our capability with regard to quality improvement. We've looked to embed this approach into the normal business of staff to make real improvements for the benefits of all of our patients. With this regard, we've successfully recruited into 3 programs of work. So the first one, where we've trained 15 to 20 improvement teams involving 83 staff with approximately 5 members of staff in each project, each focusing on a piece of improvement work on the IHI Improvement for Teams programme. And this has consisted of nearly 1,000 hours of training. The idea being all these people involved in these teams will take those transferable skills into the next projects that they're working on in relation to quality improvement. We've also trained 30 coaches to support teams with their improvement work on the IHI Improvements for Coaching programme. And the idea of the coaches is that they will have very much facilitatory skills that they can take and work throughout all kinds of other teams and projects within the Trust. And we've seen over 1,400 hours of training go into the coaches. We've also trained 30 senior leaders on the IHI Leading for Improvement programme to provide senior support for the improvement teams to effectively progress their improvement work. This is consists of around 800 hours of training. And lastly, what we've sought to do is evaluate using an evaluation framework developed using a framework to guide evaluations of quality improvement capability building. Since this started in July 21, and basically what this has allowed us to do is evaluate how successful we've been investing in this programme and the returns it's given on that investment. And we've already started to respond to some of the feedback where we have tried to increase the effectiveness of the training programmes. We've also linked it into the SHINE programme, so the Sustainable Healthcare Newcastle programme. And we've also seen that we've increased the confidence of how to apply improvement tools within the teams that have been working in this area. So I could hand you over to priority 6 now.
Good afternoon, I'm Helga. I'm going to talk to you about priority 6, which is mental health in young people. Just a bit of background that I think was touched on by our colleagues earlier on. We have seen an increase in patients presenting with mental health issues, and certainly that's noticeable within children. To put it into context, in 2017, there was about 1 in 9 5 to 16-year-olds presenting. In 2020, that has risen to 1 in 6 between 5 and 16 years of age presenting, and that is a little bit higher now. And half of all mental health issues are usually established by the age of 14 years. We know that this is not just a regional issue, this is a national issue, and there's certainly been a surge in demand for specialist tier 4 beds. Can you hear me? Sorry, can you hear me okay?
Yes, we can hear you, thank you.
Sorry, beg your pardon. So yes, as I was saying, this is a national and a regional issue, and there's been a definite increase, probably about, well, in fact, a third more demand on tier 4 beds for children and young people since pre-COVID. So there is an increase in demand. On average, people with mental health problems die 15 to 20 years earlier than those without. So it's a significant issue that needs to be addressed, and we need to make sure that, particularly for children and young people, we've got the services in place to make sure we meet that demand and we do it as effectively as we possibly can. There's a lot of work nationally from the Children and Young Persons Transformation Programme, which is in line with the long-term plan that includes how we're addressing mental health in children and young people. So what did we seek to achieve? We wanted to improve the pathways and services for children and young people presenting in the acute organisation. We wanted to improve the training that we offer for staff. We wanted to look at the environment to make sure we have the appropriate environment for young people that are presenting. And we absolutely need to learn from young people, children, young people and their families about the experiences they've had, what's worked well and what may have worked less well, so that we can improve our services. So we've set up an MDT, a multidisciplinary team, as a strategy group to oversee all the strands of work that are ongoing in the organisation to do with children and young persons' mental health. And certainly one of the focuses of that team is to benchmark with national standards of how we're performing against those standards. We have got a business case in, and that's with the CCG, and that's to look at the pathways that we have in place. The pathways for children and young people are different from those for adults, and really we are very keen to improve that, and that we are able to access mental health services more swiftly than we are able to at the moment. And we've been working really closely with our colleagues in mental health, and I think we have an absolutely great working relationship and are learning together on this agenda. We've looked closely at our policies that we have surrounding children and young people in mental health, and now we have a clear that we've got the principles in place within policy of how we manage young people under the ages of 18 who are detained under the Mental Health Act, which, having been in children's nursing for a number of years, we really didn't see the numbers that we're seeing at the moment. So that's important that as an organisation we respond to that. We've done a lot of work in improving the training. As general nurses, general paediatric nurses, it's very difficult to know how to manage a young person that comes in with a mental health crisis. We're about mending and putting things right, and there's not always an easy way to support these young people and get it right straight away. It's a long process. So as I say, we work very closely with our friends in CNTW, and they have come and they've provided training for our staff on, working with young people, strategies to use, conversations to have with young people. And similarly, our clinical educators team have gone to Ferndean and put in some clinical training for the staff across there, for children that need to be in the mental health environment, but they also have clinical needs that the nursing teams need to be offering them. We've done a lot of work around de-escalation and managing young people that are in acute crisis, and doing that in the most safest way possible. And we've got some bespoke training starting in the next few weeks for the staff that come into contact with children and young people. And that's just not nursing and medical staff. We're talking about the play staff and security staff and equipment that we can use that makes that much safer for these young people. We've just completed a part of the project, and it's called the We Can Talk project, and it's something that I got my eye on pre-COVID, but COVID suspended a lot of that training. And just to simplify what that programme is, we've had 2 senior nurses, one from paediatrics and one from adults, go away and do some training, and that training's delivered by mental health nurses, play staff and young people that have real experience with mental health crisis. They've had some training, and they've both done QI projects, very simple projects, but they've done these with the youth advisors. Part of it is making sure that there's information for the young people arriving. One of the projects is about a card in ED that allows them to show that to reception, to say, actually, I need to talk to somebody in private. I don't want anybody hearing what I'm going to say. Very simple projects, but they've been doing those working alongside the young people, and that's been really positive. Working alongside that, there's an online 6-hour programme for any staff to achieve. You can dip in and dip out. And it's very much listening to young people and the experiences they've had and why things have gone well when they've presented in the acute trust and why things haven't gone so well. And we're encouraging as many staff as we can. Our goal was 150 staff, and we've signed up nearly 400 staff now, and we will continue to do that because it's the feedback from people completing this training, and I've done the training, is absolutely phenomenal. It's simple stuff, and it's listening to young people and how they feel when they present, whether that be negative or positive, and the reasons why around that. So we will continue to roll that out. With that comes a little blue badge, which is an elephant badge. We want to point young people to what that badge means. That means somebody's done the training, and we will be putting that badge next to people that are visible on the ward on the posters, so that young people can see who's done the training and what that badge means. As I mentioned, we wanted to look at the facility. Sometime when young people come in and they are waiting for a tier 4 bed, they can be in an absolutely distressed state and can at times be a risk to themselves and to others. So we want an environment that reduces that risk. We want an environment where there isn't a lot of clinical equipment when we can, in a safe way. So we're looking at reconfiguring a room in our paediatric emergency department and linking that room to a safe space next to it, which will be a quiet, safe environment for these young people just to have some quiet time and space and get away. We will also double that up and use that when we can for children and young people that may present with learning disability and or autism and are anxious. So we will be then putting in sensory equipment to support those young people. We're working closely with the families to understand from them, from their perspective, what's worked well and what's worked less well. I've been working with a family of a young man with autism who went into crisis in our minor injuries unit, and I've listened to the experiences she had and thought about how we could do things differently, and we're working to do that. And also the equipment that she uses, the distraction tools, very simple things, but I think we need to think about how readily we can get our hands on these distraction tools in each environment, so that they're there for what young people and adults coming in that would benefit from them. Through the information we've had from families and young people, we've looked at the written information that we give, so that if a young person transfers from us to CNTW to mental health, we'll give them some information about what to expect and vice versa, because it's a very different environment going from the acute trust to then being managed in mental health. They do things very differently for the right reasons, but it's very different, and I think it's important that children and their parents know what to expect. And we've got a lot of representation on our regional and our national networks to make sure that we are continually being updated of what is happening and sharing our experiences with the regional and national teams. Thank you. Next slide, please. So I'm going to also talk to you about priority 7. That moved, yes. And that's ensuring we've got reasonable adjustments for our patients with a suspected or a known learning disability, and also patients with autism. And we know that people, which is children, young people and adults with learning disabilities, are 4 times more likely to die of something that could have been prevented than within the general population. And so we need to make sure that, you know, we're reducing those risks, and we're making sure that our staff understand what are reasonable adjustments and what we can do to make sure we put those in place. So the things we looked to achieve were to continue to review and improve the learning disability liaison support service we have for children and their families and adults, to review the training across the organisation in terms of learning disability and autism, to look at what national and local initiatives there are, make sure we are benchmarked and we're implementing those. And again, as in the last priority, to make sure we learn from our patients, their families and their experiences that they've had. So we have a learning disability liaison service. It isn't big, and we know that, but we are looking for investment within that team. They work across the whole of the organisation, so they look after children, young people and adults. And we've thought of ways that we can do things differently. We want the team to be more visible so that they're out there on the wards, and we have been able to invest some staff to be what we're calling ward walkers. So they are out and they're seen and they're talking to patients and families and the staff across the organisation. We're looking at the role of champions, which are people that we have there that can be called on for advice and support around learning disability. We want to review that, we want to update that. We don't necessarily need it just to be nursing and medical staff. We want people with experience, and we want to make sure that these people that we have as champions have a level of training and expectation. We're also looking at doing something very similar for autism, and are looking at implementing some autism training in adult ED initially to start with, and then looking at the concept of autism allies, which would be very simple to the learning disability champions. There's a lot of digital improvements going on at the moment within the organisation, so that the learning disability team, for one example, can see when patients are coming in, when they're on the waiting list. They can go onto this virtual site and they can see which patients are coming in with a learning disability, and that helps support the planning and the preparation in a lot of the cases that need a lot of planning. We're also looking regionally, we're looking at digital passports, and we're also looking at potentially being a pilot for a digital passport with a piece of work that's been completed with NHS England. Very early stages, but it's something we're looking to see if it will link with our software and just exactly how it will benefit. We have a leader process where we review the deaths of patients from a learning disability. We'll be doing the same with patients with autism moving forward, and we continue to learn from that process and to share the learning from that process. We're doing a lot around making sure that on the system, when a patient comes in with a learning disability, that there is a flag on there that will allow the staff to look further into the details to see why there is a flag, what that means, what reasonable adjustments are required to make the experience for that patient and their family better. And something we're looking at is how we will do that for patients with autism. From a training perspective also, the Learning Disability Regional Network devised what is called the Diamond Standards. That's a process for ensuring acute admission, elective admission and discharge are managed in the most appropriate way across the organisation. We're rolling those standards out. We've been waiting a long time for some training, which is called the Oliver McGowan training, and that was on the back of a young man that was over-medicated and sadly lost his life. We've been waiting for a long time for this training. There's some initial discussions about when that's going to be launched in May. So as an organisation, we will be attending that to make sure that we're on the foot for rolling that out, and that will be rolled out alongside the Diamond Standards for staff. We'll have regular forums. The Learning Disability Liaison team will do bi-monthly forums to share what has gone well and what's gone less well and what we've learned. And then we have Learning Disability Week and Autism on the 20th of June. So we're doing a lot of planning around that and looking at doing a lot of various things across the organisation to highlight Learning Disability Awareness Week, and what reasonable adjustments are and how we can make sure that we've got those in place. And I think that's it. Thank you.
Hi, so I'm just going to talk through the last slide, which is our proposed quality priorities for 22-23. As you can see, there's a bit of a continuation because these were very big projects and we always want to do our continual improvement cycle. So as Cheryl described earlier, we are going to focus again on our gram-negative bloodstream infections. I discussed the management of abnormal results, which is in progress and obviously will continue. Helga's obviously just described from a patient experience point of view the ongoing work with learning disabilities and children with mental health issues. Gavin described the enhancing quality in QI, which will continue. I just want to draw your attention to the deterioration of pregnant women. So we're going to focus on very much an introduction of a formal triage process in the maternity assessment unit in order to improve the recognition of the deteriorating pregnant or recently pregnant woman. Obviously, the aim will be to reduce the likelihood of avoidable harm to mothers and babies. And obviously, we need to improve our early detection rate and rapid escalation of women at risk of deterioration in the maternity assessment unit. And then we will continue to move forward with our MEOWs implementation across the Trust. Our other new priority was the Trust-wide Day Surgery Centre, which Angela O'Brien mentioned at the beginning of the presentation, which again will provide a day case environment set for day cases only to help obviously enhance the patient experience and also assist to reduce waiting times. Regretfully, our director, Angela O'Brien's had to leave to join another call, but we're all happy to take questions. And if we can't answer your questions, obviously we'll take notes and get back to you if that's okay.
Thank you very much. I'm just going to ask now, committee, any questions? Councillor Hunter.
Thank you, Chair. It's just on the inpatients for the people with special needs and that. Do we have still enough capacity to deliver local? Because naturally it's easier to deliver local and transporting these people out of county, out of area, out of region even. And I'd hope that we can try and deliver as much as possible local, even though the numbers have went up.
I would say absolutely, if that's within the pathway and that provides them with the most appropriate care, and that's where our learning disability liaison team can help support with that. So if we could avoid the patients coming in, that's what we would do.
Any other questions? Councillor Bowman.
Thank you, Chair. Amazing report, by the way. Post-COVID, and is absolutely phenomenal to read. Thank you for all the hard work that you do and the many lives that you save. It is absolutely tremendous. Can I thank you for looking into young people's mental health? It is an issue that is of concern to myself. I've had dealings in my community with young people, well, a young person, sadly, who had a lot of problems, and it was very challenging to get him help. Obviously, you are looking into that, and I want to just say thank you, because it's needed. It is an area of healthcare that for decades has been neglected, and I'm really pleased that it's been looked into in these latter years. It is a concern not just for the patient themselves, but their families, and the support needs to go into their families as well to back up what you're doing in a clinical sense. It is harrowing for a lot of families to have to deal with a child who has mental health issues. Is that part of your remit as well?
Yes, and just to reiterate what you've said, as I say, I trained as an adult nurse to start with, but I've been a paediatric nurse the majority of my career, and I've never probably witnessed anything like we're witnessing at the moment, and the effect that it does have on the whole of the family, as you say, is really challenging and difficult, and we need to work with the families as well. And one of the things that I was talking about, the two nurses that did the We Can Talk project, one of the QI projects was welcoming any young person that attends. One of the feedback we got was that they felt, not necessarily in our organisation, this was from the training, in some organisations they felt they were time wasting and that they shouldn't be there because they need to pull themselves together type of feedback that they were getting. So one of the initiatives was to give them a welcome pack. We want you here, we're glad you've come, we're going to look after you and we're going to keep you safe. And part of that is some support for them of a range of differing organisations, charities that can provide support on discharge as well, so that we're already thinking about how we can support on the discharge when they're admitted, and part of that as well is how the families, the parents can be supported, and the siblings, because it has, as you say, it has an effect on the whole of the family. It's really hard.
Thank you very much for that. I really appreciate it. And like I said, what you're doing is absolutely amazing. And I'm really pleased that you're looking into the priorities you are. They are, in my view, absolutely amazing priorities. And the fact that you're looking into pregnant women's issues as well, which will save lives. Thank you very much.
Thank you. Derry, I think yours, and I think that's the last question. Derry.
Thank you, Chair. Debbie Nugent from Health Watch Northumberland. I think I'm going to pick up perhaps a bit on what Councillor Hunter was talking about and about the delivering locally. I think through the report, and certainly in the additional information that we've been handed on paper today about engagement, it would be, I think, really good and helpful for residents in Northumberland to see how their experiences are reflected through your quality account. We know that from people who are feeding back to us that sometimes they feel they don't have access to your services, and it is more difficult. And I think last year we raised the issue of audiology services with you, and heads up, we'll be raising them again through our response to your quality account. So I think when you're talking in your report about engaging with the public, that would be really helpful, just to reflect that it's not just Newcastle, it's not that you're dealing with, it is Northumberland as well, and I'm sure on behalf of colleagues in North Tyneside as well and other areas. But in terms of sitting here today, it would be good to see a reflection of the Northumberland experience as well.
Yes, absolutely. We'll take that on board, and I'll feed that back to Angela O'Brien as well, so we can reflect across all of the region. Thank you.
Thank you. Well, there aren't any other questions, so can I thank you all very much for doing this presentation, and we will respond with a formal response to the Trust on your accounts. Thank you. And thank you very much indeed.
Thank you.
Thank you.
Sorry, we'll move on now to the Health and Wellbeing Scrutiny Work Programme. Chris, do you want to just take us through there?
Yeah, obviously NIAS did their quality accounts in April, which is why we've had them at this meeting. Because we had to defer the quality accounts, we've had to move a lot of what was due in the next couple of months further down the line. So it was just to make members aware that at the next meeting we will have the 2 reports following the dissolution of the partnership with Northumbria Healthcare. That was a request from the committee last summer that in between 9 to 12 months some sort of review or feedback came to this committee. So that will be coming to the next meeting, as well as the restructure of adult social care. And then in July we'll have the extra care and supported housing strategy, which was a decision taken by Cabinet a couple of years ago. Again, that will be an opportunity for the committee to see how that's been implemented, and we'll have the annual report on the adult social care complaints. And that's all I really want to say about that.
Thank you. Has anybody any comments they want to make about the work programme? You're happy with it? Right. In that case, the next item is urgent business, and I do have one item, which is to introduce Neil Bradley, who's sitting at the end there. I think some of you will know Neil, but for those of you that don't, he is our new Executive Director of Director of Social Services following the departure of Kath McAvoy-Carr. Welcome, Neil. We're really pleased you're here. Thank you. And I think that's it. The date of the next meeting will be also in May, the 31st of May at 1 o'clock. Do we know yet? Will we be back up in the meeting room?
Back upstairs.
Back upstairs, yes. So I thank everybody for coming.
I wish you told me that at the beginning, because I was working out what.
That was just to give you something to be doing. Yeah, so thank you all for coming, and my thanks too to the technical team who've made sure that this hybrid meeting has actually run quite successfully. So thank you. And I think that's it. Safe journey home. Can we stop the live stream, please? Thank you.